So what is the best method to determine if you need a biopsy, to determine if, what's the clinical stage of your prostate cancer? Today's conversation is with Dr. Ashley Ross, who's an associate professor in urology and clinical director for the Pulaski Urological Oncology Center at Northwestern Feinberg School of Medicine. Dr. Ross is an accomplished clinician and surgeon specializing in prostate cancer, genomics, immunology, targeted therapies, and clinical trials. His research is primarily to enhance the diagnosis and treatment of clinically significant prostate cancer, including the identification of prognostic and predictive biomarkers and the initiation of clinical trials. Dr. Ross is trained at Johns Hopkins, one of the premier institutions in urology, if not all of medicine, and he has a PhD from the same institution, Johns Hopkins. We discussed today his approach on personalization and determining who is that person that needs a biopsy. We had a great conversation on no one wants a biopsy. I don't want a biopsy. Your urologist doesn't want a biopsy. So who needs it? How can we personalize the approach using the tools that we have now, including genomics, which Dr. Ross is one of the primary authors of a recent study on genomics in men on active surveillance. Please enjoy this amazing conversation with the one and only Dr. Ashley Ross from Northwestern School of Medicine. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. And now I'd like to acknowledge our three amazing sponsors that you will hear about throughout this podcast. One is XY Wellness, a company I'm very familiar with as co-founder and medical director, a lifestyle company, XY Wellness, specific for men with prostate cancer. Next is Veracyte, the makers of Decipher genomic test. After a biopsy or even a prostatectomy, you want to know how your cancer may behave. This is how the genomic test Decipher can help. Third, ExoDX. Prior to having a biopsy, you want to know if you really need one. And the ExoDX test, a urine test, is very helpful to determine if you need a biopsy or if you don't. Thank you to today's sponsors. Welcome to the Dr. Gio podcast. I am your host, Dr. Gio, where it is my goal and intention to help you improve, if not optimize, your prostate health, all things prostate, including prostate cancer, optimize hormones, sexual function, and how do we live better with age. My great guest today is such an honor, Dr. Ashley Ross, who you know much about from the intro. Ash, thank you. Thank you so much for being on this late day.
Thank you. Thanks for having me.
Ash, so as I don't want to repeat many of the topics that I've had before with other amazing experts in the field. So I was thinking, all right, what do we talk about, right? Because I have an episode of active surveillance with Aditya Pragodia, although that's always a nice conversation. I have a Gleason 7 with Minhaj Siddiqui. And so, well, then genomics. I said, well, there's always a different angle as to when we talk about even active surveillance or genomics, the application of genomics. And understanding the audience, the reason why I have this podcast is because I want to disseminate the best information possible as it relates to integrative medicine in prostate health and urological function, right? Because there's a lot of things out there that are not so great. So I have all you guys, the experts around the world. So we want to avoid confusion as to how can the person, the self-health advocate who goes to you be well-informed, because we have this discussion with everyone on mutual or shared decision-making, right? The patient wants to have a well-informed self-decision-making or shared decision-making. They want good information, so they go to you, is more efficient, you're seeing 30 patients, et cetera, right? So this is the platform for that. Many of our listeners are self-health advocates and a few practitioners. So with active surveillance, everybody wants active surveillance. Certainly people that listen to my podcast, and sometimes it's just not an option. What is your approach to determine if someone is a candidate for active surveillance? And then we'll go deeply into histology and all these things. What's your general approach? What are you looking for? What's your process?
Yeah, I would say, first of all, there's a little bit of a distinction for active surveillance and watch. So the first thing to do is we make that diagnosis and we think about what's the overall health and life expectancy of the individual. Now, usually the people who are coming for screening have 10-year life expectancy. But, if someone has a more limited life expectancy and for some reason they've had a diagnosis now of prostate cancer, sometimes we're just doing watchful waiting, meaning looking for symptoms and then treating them to contain the disease if it's showing that it's becoming symptomatic or spreading. And so those people are off the table. So one thing is, to be a candidate for active surveillance, you have to have a good life expectancy, be a healthy man, because the idea is we're surveying the cancer until the point where it needs treatment, if ever, and then we're intervening with curative intent. And in prostate cancer, interventions with curative intent really benefit those with at least a 10-year life expectancy. Mm-hmm. So that's one thing. And then this looking for is what is their overall rate? And as the audience may know, for a long time since Anthony D'Amico, who's a radiation oncologist, sort of came up with a sort of a nice framework in which we can look at different risks of localized prostate cancer. And these were like risks of recurrence after treatment, but they've been validated for lots of things like risks of progression on surveillance, et cetera. And traditionally, we think of men with low risk or favorable intermediate risk prostate cancer, or if you use the NCCN still, very prostate cancer as our surveillance candidates. And we'll get into some minutia there. These are people who, as you mentioned, will dive into the Gleason grades, where the cancer doesn't look that undifferentiated. The cancer looks like it, under the microscope, looks like it remembers that it still is prostate, like it's trying to form glands and do things. PSAs are lower. The tumor in the patient's prostate even is slightly potentially on the lower end. Those are our candidates. Medical jargon, it would be the NCCN favorable intermediate risk patient and less. And we have very good evidence.
Gleason 7, 3+4, not 4+3.
Yeah, so I was going to get to that. So we'll dive into jargon. So for the jargon, so to dive in that a little bit, when you look at the cancer differentiation in audience, Dr. Gleason was trying to determine under the microscope how much the cancer looked like it was differentiated, or like things that prostates are supposed to do, forming glands, et cetera, versus had lost a lot of the rules that guide cells. Contact inhibition, meaning like they're getting too crowded or they're forming structures that don't make sense. And he was scoring them. And now, to help the patients think about things, we've moved towards Gleason grade groups that go from 1 to 5. Because Gleason grade group 1, the lowest score is 3+3 = 6. And that's because a lot of the lower Gleason patterns were not actually cancer in some ways. Mm-hmm. So Gleason grade group 1 or 3-3-6 or 2, 3+4 = 7, those would be low grade or favorable intermediate grade. And if you combine them with PSA less than 10, a rectal exam that's not too concerning, now you've got your low and favorable intermediate risk categories. And there's some men that the NCCN designates at very low risk that have even less of the low grade cancer. And these are your surveillance candidates. Now, Dr. Gio, you bring up a good point, which is, what happens when you do a biopsy and you find a small fragment of 4+3 = 7, which means under the microscope, the pathologist says there's more of the aggressive stuff than less aggressive stuff. This is a Gleason grade group 3 instead of 2, but the complete volume of what was biopsied was a fragmented core that might be 2 millimeters of 4+3 = 7, whereas the other guy who had like 1.5 centimeters of 3+4 = 7 with 30% pattern 4, he's favorable intermediate grade, but he actually has more of the bad stuff. So let's leave that aside for a while, not so that we don't confuse the
In other words, let's break that down. Let's unpack that just a tad, because I know exactly what you mean, and I love that conversation. What if you have, what's the difference between and my audience knows Gleason scores very well because they've been listening to the podcast. So what would be the difference between a Gleason 7 3+4, which most people would say that's low intermediate risk, that's a little bit bigger in volume, versus a a Gleason 7 4+3, which most people say, yep, that's not low intermediate risk, but it's very small, little tiny tumor that's a 4-3. What is the difference between these two? Let me add to that because I saw a case. I saw a very tiny Gleason 8. I'm talking about like I think it was 1 millimeter, I want to say, and that's it in the whole prostate. So where does that guy land, right? So
Yeah,
go
and
right.
I think just for your audience that might be savvy, I would say two things. One, for us as clinicians that are practicing, we have to think about, well, was that tumor adequately targeted? So, for example, if the guy had a PIRADS 5 lesion on their MRI, so that's usually like either a 1.5 centimeter lesion or maybe has definitive EPE, maybe it's in a tricky place, and the guy comes back with a core that has maybe 2 millimeters involvement, you might say, well, maybe the biopsy is not representative of the tumor volume.
Today's discussion is brought to you by yet another amazing sponsor, Veracyte, the provider of the Decipher Prostate Genomic Classifier. Here's the deal, folks. After a prostate cancer diagnosis, what you want to know is, how is my cancer different than any other? The Decipher test helps personalize the diagnosis a little bit better so that one knows how aggressive their cancer is, because we all know that not every prostate cancer is created equal. I clinically use the Decipher test almost every day as it helps me determine how is this particular patient in my office, prostate cancer, different than the guy I saw earlier today or different than the guy I saw last week. How is their particular tumor behaving differently or will behave differently? That approach helps with the shared decision making between you and your clinician as to what's next for me. What is the best approach? To learn more about the Decipher test, please visit the link below in our show notes.
And sometimes for that guy, they get the privilege of getting a PSMA, and the PSMA can be avid. We're looking for metastatic disease, but as clinicians, we can look in the prostate too and say, oh, we're getting a lot lighting up here. The biopsy may have undersampled them. So you have to like look at multiple data streams. But to your point, what we're looking at, I work with a really nice guy, Lee Cooper at Northwestern, and he's our head of augmented intelligence for pathology. And we've been developing different digital path algorithms, as lots of people have, that are like where you digitize slide and then it's going to show you, is this cancer or not? What does the AI say the grade is? And there's some company stuff too, like Artera, that looks at like prognostic signatures. We've been looking at molecular signatures as well. One low-lying fruit thing is what you were talking about. Are we actually quantitating the amount of cancer found on the biopsy appropriately? Was it appropriate to say, well, you have one core of 437, that's unfavorable intermediate risk, for the guy who has three cores with higher volume of the pattern 4, but 347, they're favorable intermediate risk. And there's been already a lot of research around this, but I think with the AI, you start to get a faster way, a less cumbersome way, where you can start to look at quantitations. And we have a few of our residents and fellows at Northwestern that are trying to like parse out, well, if we look at the disease volume this way or that way, what's the better predictor of like final pathology at prostatectomy? It's very like low level stuff, but as we were just talking about, kind of important. But to bring us like back to home base, when we start thinking about surveillance, what I'm usually looking for is the run-of-the-mill guy with favorable intermediate risk or less. And I think, given the PROTECT study, which was your audience may be very familiar, a randomized study in mostly in the UK of folks getting kind of a slightly looser type of surveillance versus surgery versus radiation, and showing no real overall survival difference at 20 years, it tells us that anybody with favorable intermediate risk and lower should at least be approached that surveillance is an option, and should understand that about a quarter of the patients on surveillance could stay on surveillance indefinitely, and maybe understanding how your tumor evolves over the course of some period of time, whether it be 1 year, 2 years, can give you a lot of insight on are you good for surveillance forever, or do you come off? And it's maybe worth figuring that out so you can continue with your perfect sexual function, perfect urinary function, no life disruption. It might, and that's kind of what I'm looking for usually, is favorable intermediate risk and less. It's rare that I'm trying to shoehorn the unfavorable intermediate risk guy into surveillance. I think that there's other folks, Lori Klotz and others, that a little bit more routinely a lot. I think that the way to approach that is in a very conscripted clinical trial type fashion, just so that like And we probably would bring everything to bear in that. A lot of the digital pathology, AI on the imaging. We have a guy named Ulas Bagsi who works on that. And we would try to bring everything together to see, well, what are we actually being tumor burden, and how well do we just understand the tumor progression by its molecular level and what we see on the slide.
Wonderful. Wow. Thank you for that. What role, and you just published a paper, JCO, I believe, on using genomics for active surveillance patients. Yeah. So you can talk about your results and outcomes from that paper, and the role of genomic testing as it relates to men on active surveillance. And let me take that a little bit further. For example, is there such a thing, right? So we all say, Scott Egner, our friend, said, well, we shouldn't call it cancer, right? It's a Gleason 6, right? If it's a Gleason 6, we shouldn't even call it cancer. So back and forth, I had Kaibo who said, no, it is cancer. Molecularly, it is cancer. So it was nice. We had them separately, no debate. But can we apply genetic testing to a Gleason 6 where there is such a thing as a Gleason 6 being high risk based on genetic testing where, yeah, this person needs treatment? Is there such a thing?
Yeah. And so I think there's a few things to unpack there. And like what we're all now looking for in surveillance is we are starting to understand what the boundaries of surveillance are, but then we're understanding that inside of the patients that we put on surveillance, we need like a risk adopted strategy. So in other words, for some of the cancers that are lower volume, lower grade, and maybe have selective genomics, do we need to survey them as closely? Like how often are you doing invasive things like biopsy, or
Sure.
doing expensive things to the health system, and even disruptive things to the patient like MRIs that are non-invasive?
And the biopsy component is this. So this is the dilemma that the patient faces. Oh, I'm a candidate for active surveillance. Great, thank God. Wait a minute, biopsy every year?
Yeah.
For how many years?
Yeah, so we're looking at, and lots of people are looking at, there's like a Movember initiative around this, and lots of people are looking at this, is okay, well, we have to think about a little bit about how folks are diagnosed. There was a nice paper by Cooperberg that was showing that they weren't finding a lot of cancers anymore. And that means like infinitesimal amounts of low-grade disease. And we looked in our Northwestern series, and we're still finding about 10% rate of very low-risk disease. Now, for the audience, that's really small amounts of low-grade prostate cancer. We know favorable PSA density, meaning that the PSA divided by the gland size makes sense. Small amounts, like less than half the core involved, a couple cores involved. And we're still finding it. And why are we still finding it? A lot of it has to do with the system biopsies. We do the targeted biopsies from the MRI, but a lot of us are still doing systematic biopsies sort of offline. You and I were talking earlier about focal therapy and things like this. And we do it to see if a patient's a candidate for focal therapy. We do it for surgical planning. Like if they have no disease on one side, we might be more inclined to do a more aggressive nerve sparing. But those systematic...
Very quickly, if you can, before you move on, if I may ask you to pause, describe the difference between systematic and targeted. I don't think my audience is really versed in that.
So, this, and I'll back up just so that they can take this information with them if some of the audience is pre-cancer diagnosis. In the NCCN, the National Comprehensive Cancer Network, there's a really nice flow chart of how you can think about elevated PSAs and how you would go about your diagnosis. There's only one category 1 recommendation in that flow chart, meaning really supported by great evidence, which is, if you're going to think about a biopsy, when available, an MRI should be performed first. So right now, the vast majority of our patients should be getting a MRI prior to their biopsy.
And which is not happening in much of the country.
Yeah, which is really unfortunate. And there are things around that might be limitations, like access, MRI worth anything? Are they actually being read correctly, performed correctly? But the goal supported by high level of evidence is that you should have an MRI prior to your biopsy. And why is that? There's high level evidence that suggests the major thing is the negative predictive value. If you have a clean MRI, and you trust it obviously, but a clean MRI, then you often do not need to do a biopsy at all. And that will save you from diagnosing these infinitesimal amounts of low-grade prostate cancer that a lot of, like maybe half the population over the age of 60 are walking around with and don't even know it.
Clean MRI defined by PIRAD 3 or higher?
Clean MRI is saying PIRADS 1 or 2 would be clean. So that clean MRI, the opposite you were saying. So for the audience, again, there's a prostate imaging radiology assessment, like database system or whatever, a PIRAD score that and just like I was saying, the Gleason grades go from 1 to 5. we like in medicine 1 to 5. For the patients that are listening,
Right.
when we give you 10 choices, you think there's too many options. If we give you 3, you think we're lazy. So we like 5. And essentially, if you're 1 or 2 PI-RADS, that means that the MRI, a 1 is clean, and a 2 is they see something there, but they're sure it's not cancer. The negative predictive value in that scenario is very high. Now, there is some data that might be modulated, like that maybe it's slightly lower in African-American men. We're not quite sure in all categories, but by and large, those people can avoid biopsies and you won't miss bad cancers. So that's the main reason to get the MRI is better cancer detection. Most of us are I use computer fusion, I use Urinav. A lot of people do cognitive fusion. Some people use other systems like Coelis or whatnot. But we can use the MRI targets, and there'll be a bullseye on this is where we think the money shot is, and we can go after that. And so then that would be a only biopsy. The advantage of a target only biopsy, where you go in and you're going to biopsy that target, and I do mine as transperineal biopsies to limit the use of antibiotics and also to have.
Are you doing mostly transperineal these
I do
days?
100% transperineal biopsies. So,
Interesting. Okay,
and
yeah.
again, not to go too much on, but you don't seem to mind.
I'll bring you back.
You don't seem
if
to
I have
mind.
to.
Additionally, we have to see the prostate in some way, and so there's a transrectal ultrasound. No matter which way you're doing your biopsy, that transrectal ultrasound sees the prostate in real time. And that's often you're going to have an overlay of the ultrasound with the MRI fusion biopsy. Some providers will do that in their mind. I use the computer fusion. And then you're going to put it. And the question is the needle going through the rectum or is the needle going through the perineum? The perineum is, for the lay audience, if I can use the word, it ain't the scrotum and it ain't the anus. It's the area in between the taint. That's the perineum. And you're going to be going through that skin. Now, the advantage of that is I do those primarily in clinic. With the fusion registration, it takes me 8 to 10 minutes for the whole procedure under local analgesia, meaning usually buffered with some bicarb. And I use no prep, no antibiotics, no enema, no nothing, right? And so the other system, which I used to do, is I used to go through the rectum, and that is that a lot of the food that we eat and a lot of the overprescribing of antibiotics, but I think it's really from a lot of the food we were consuming, giving us resistance in our guts to antibiotics a priori. So for lots of different reasons, we won't go into all of them.
Our audiences are familiar with that, but I can't believe here you have a medical doctor, MD, PhD, who's saying, hey, maybe from some of the food we eat, we're getting resistance for antibiotics. You're right on, and I know we can go into 5 different tangents.
So, but long story short, been a nice randomized study on multi-center by you and Ted Schaefer were the leads that showed that infection rate is lower or at least similar and very low, whether you do a transrectal biopsy use swab to tell you how to gauge the antibiotics you use, or if you do a transperineal biopsy with no antibiotics. And for me, I also am thinking about a population level. If we can do a procedure in the same office time with the same amount of discomfort and minimize discomfort, I should say, but it's the same amount either way, and one procedure, nobody's getting antibiotics, like no antibiotics. I'm talking about even like kidney transplant patients that are being evaluated, they're immunosuppressed. I don't use antibiotics. So nobody's getting antibiotics versus everybody's getting some kind of antibiotic or sometimes 2 antibiotics that are broad spectrum. I usually am looking at the patient in front of me, but every once in a while, I got to think about the population. And population wise, we should be doing the one that's transperineal. Meaning like no antibiotics, in and out for the patient, no risk of infection. Yep. The problem is, and patients might say, well, my provider's not offering that. Yep. And one of the issues has to do with how American medicine works. And we won't get into that, but like you need different equipment to do a transperineal biopsy. And there's disposables that are used to make kind of doable. I use Precision Point, but there's other ones that kind of help you keep the needle where you want. And that costs money too. But the medical system isn't giving us more reimbursement for doing this thing. And so if you community practice and they say, well, I'm going to have to lose like $500 or $100 or whatever it is every time I do a biopsy, if I do it this new way, why should I do it? And unfortunately, for some of the medical coding and stuff, like a lot, and again, for the patients, I'm sorry, but like sometimes money talks, and the provider's saying, well, Center for Medicare Services, the insurance companies, the coders, they're not saying this is more valuable, that it's more valuable for the community to decrease the amount of broad spectrum antibiotics there. They're not giving me the ability to operationalize this in my practice, even for a year or 2, That's usually what the provider wants, is increase it, then come down. I can't do this. I can't do it. For me, I'm lucky. I'm at Northwestern. It's a behemoth institution.
Our guys are at NYU,
Yeah,
Sloan, right?
they
So
can say, look, it's okay. We know it's better. We'll do it.
yeah,
But I
yeah.
mean, I guess it's like if there's someone from like coding, or when I think about what the AMA might, AUA or AMA might try to put their foot down on, they should put the foot down on saying like, let's drive this like a better behavior. Let's drive it by boosting reimbursement for a short time.
Today's discussion is also brought to you by the makers of the ExoDX test. The ExoDX prostate score is a non-invasive, no DRE necessary, so no finger up, no prostate exam necessary, urine test to determine if you need a biopsy. Now, we all know the issues with the PSA test. It is a great test in my clinical opinion, but is imperfect. So what else is out there to determine, you know what, I really need a biopsy? Unfortunately, there's no other way around it. That test is the ExoDX test. Again, a urine test, pee in a cup, send it to a lab. It gives you a score. If the score is above 15.6, you likely need a biopsy. If it's below 15.6, you may not. So this urine test, the ExoDX test, should be part of the decision-making, part of the shared decision-making between you and your clinician on whether or not you need a biopsy. To learn more about the ExoDX test, please visit the link below in our show notes.
And then we'll decrease it back down. And that's a totally different discussion of how medicine works. But regardless, that's the target. The MRI showed something, I'm going after it. So that's going to be your money shot. Now, the systematic is saying, well, here's the prostate. There's one area of the target. I'm going to target that with my biopsies. I could have had misregistration. I could have a cancer that's MRI invisible. I'm going to sample kind of systematically around the prostate. A lot of those are in the peripheral zone of the prostate. So I can make sure that if I tell the patient we didn't find anything, that I feel more confident that we didn't find anything.
But it's not quite a blind biopsy like an ultrasound, like people do
Correct.
with ultrasounds, right?
It's like, the systematics are you're not seeing any lesion for the systematic biopsy, but you're biopsying areas of the prostate that you think are higher yield for having occult prostate cancer. And what the positive of that is you get a great idea of the landscape of what's going on. If the cancer is like, if the cancer is like a bucket of paint that's spilled on the floor, you get a great idea of like not only where that big blob of spilled paint is, but where the spray is around the floor. You get a great idea of that. The negative is you can detect incidental small amounts of low-grade cancers that if you avoided the systematic biopsy, you would not have detected. And then those patients now have cancer. If we don't go by Scott's kind of plead for not calling them cancer, those patients now have cancer, and now they're saddled with the anxiety over that. And they're also saddled with, like you were mentioning, perhaps a lifetime's worth of biopsies. And so for us as providers, we have to say, okay, if I'm going to be someone who does the target and the systematic biopsies, I also have to be someone who identifies if I have a cancer that's small, it's going to be moving like a snail, how do I de-implement or take away the amount of biopsies the person has? And we're going into a pattern. You asked about genomics. There's the NCCN calls out this as like one of the genomic tests with level 1B evidence now. And that's the preferred genomic test, I would say, to use in prostate cancer. What I do now is if I have a guy where there's no red flags, the MRI is not a PIRADS 5, so the radiologist scoring system is less than that worst score. The PSA density is less than 0.15, so the PSA is not punching above its weight. The Gleason grade group under the microscope is grade group 1 only, and the Decipher score is low risk. Then I'm telling that guy, look, your cancer appears to be not huge and moving like a snail. Let's not do a confirmatory biopsy for 2 years. So let's wait for 2 years. If we don't get any warning signs, and that's when we'll do the next MRI and biopsy, and we'll get an idea of, I can't draw a line without 2 data points. We'll get an idea of the slope. And if it looks the same, then no more biopsies. We'll do a PSA every 6 months. You do one with your physical, one with us. We're going to check an MRI 4 years. The MRI looks kind of similar. Then we'll keep going that way. And where I'm getting that from is on Protect, the trial I talked about before. Once you were on study, that was active monitoring. They only did biopsies if people had 50 elevations in the PSA that were sustained, or they felt something new on their finger, that would trigger more workup. And yes, they had some misses. And I think for myself, I don't want to tolerate someone becoming metastatic on my watch. And so if I add back in, well, we're going to do a couple routine MRIs at 4-year intervals because new cancers can develop. That's what I feel like for them. So that means for the group listening to this, people with minuscule amounts of low-grade disease, once you establish that slope of your curve flat, you should be thinking about de-implementing biopsies, de-implementing MRIs even, and minimizing the idea of cancer in your life. And I think that's a better way of...
That's a tough sell, right? So the cat is out of the box. C word is already there.
It's there I think there's a couple of things. One is I sort of think that I like Scott was thinking about, well, should we really call this cancer? And I worry about people not following up. That's the worry if you say it's not cancer. Yep. But I think you have signs that this cancer is moving like a snail. Then essentially what you want to tell the person is a couple things. You want to use it for good. So how do you use the cancer diagnosis for good? Well,
lifestyle changes. You're so motivated. You're way more motivated than you ever were. You're exercise hours a week. And this is the motive. I do have a podcast episode with just me, and the title of that is Why I Love Gleason 6 Prostate Cancer.
Yeah, so that's exactly it. That's exactly it. And actually, as you well know, in the different studies that have looked at like lifestyle changes and how they affect progression of the cancer, it's a little bit muddled. And I think that some of that, like Mary Pass, which is a Californian study, which is West Coast surveillance study, they show when they had lifestyle with different diets, they didn't see much of a difference. But if you look at the BMI of those patients, they were all like average like 27. So these were like healthy guys from the Pacific Northwest and the West Coast that were every day they open up to a mountain, they go for a hike, and they feel great. Then there was another study called PALS, if I think correctly, that looked at like specifically higher obesity men. BMI was like in the 30s. And there, they only have some preliminary stuff about changing diet and them following it's a guide to drop 7% of their body weight. And some of the metrics of the gene level metrics were changing that looked favorable. So regardless, a lot of men, and I'm going to be shameful to say this, my partner will really get on my case. I've only gotten a few physicals in the last like decade. And they've been for like life insurance purposes, for employment purposes. And there's more men like me than not, meaning that they don't even really are fully established with their doctor, but somehow, or they're seeing them here and there. And when I had those assessments, they did my PSA, but sometimes the having a cancer diagnosis that's low grade, like you said, can be a wake up call. Like, I want to optimize my life. And cardiovascular death is a huge cause of male death, and optimizing for that is the way to go. So I'll look forward to your podcast.
So I think for the last 5 years, for the first time in my life, I've started mentioning how aggressive lifestyle interventions can actually have an impact on cancer in terms of creating, you talked about the soil. I love that analogy. Creating a microenvironment around the tumor that's hostile to that. And I think there is something there, very difficult to prove. There's a lot of variables. Also, when they talk about lifestyle, in my practice, I'm ultra prescriptive. And I think there's value there. And when you look at some data where they're a little bit more prescriptive, you see better outcomes.
Oh, yeah, for sure. Like I don't want to misquote it, but in that PAL study, when they were using like prescriptive dietary interventions versus just telling people about it, huge differences in patient adoption. The second thing to say is like, I am a believer in that hostile environment too. What I think that we have to look at, or where I've seen it do things anecdotally in my patients, is usually the person who is more out of bounds. Like the more out of bounds you are, meaning like the more, I don't want to say these are the things, but the more obese you are, the more processed foods that you're eating, like even things like smoked meats and stuff like that are like, I think they're category A carcinogens, like smoking level.
Smoked meat.
Like
that's a very important, but we'll talk about that because the preparation of them, all meats are bad. Well, systemic and meta-analysis are suggesting it's not the meats, but it's more details, how it's prepared and this and that and the other.
But going back to the main topic, when I find the person who has a cancer that I feel, we diagnosed this really by accident. We were trying to be thorough. We found this small thing. We think that the genomics tell us the other characteristics in the microscope even, or other prognostic factors are telling us that there's a small amount and it's moving like a snail. That person, we want to do as little biopsies as possible. And the patients, as they see their confirmatory biopsy comes out the same as it was before, I think they can get a sense that's the curve they're on, and we can be on that. For the other patients that are higher volume disease, 3 + 4 = 7, Gleason grade group 2 disease, there, I think it's important to counsel them that surveillance is a well-established strategy, but we have to understand that the majority of patients that start on surveillance are going to end up with treatment. That it's not, for the majority of you, about 75% of the folks, it is kicking the can down the road. And that
Is
can be
that due to fear or the progression of disease?
even in Protect, which had sort of a more stringent bar for treating people. And if you look at like how many people actually went their lifetime without getting a prostatectomy, getting radiation, or getting like hormonal therapy forever, right? Or getting locally advanced disease, it was only about 25%. Now, you bring up an excellent point, and this is something that I'm trying to push at my own institution, and I think that the patients should advocate for themselves is, when is progression really progression? Like, is going from 4 cores of low-grade disease to 5 cores of low-grade disease, is that progression? No. And I think that for the majority of providers that aren't completely locked in, that are with prostate cancer, they have been too relaxed about what they're going to say. Well, I think you have to come off surveillance. And what we're thinking about doing is twofold. There's some progressions where everybody knows it. Going to unfavorable intermediate risk cancer, for example, forget the nuances of the volume of disease. That would be everyone would say, well, this guy used to have 336. Now he's got 2 or 3 cores of 4 + 3 = 7. Everyone would say that's progression. Even worse, and we hope these never happen, the new MRI before confirmation shows seminal vesicle invasion or lymph node positivity. Everyone would say that's definitely progression. How about the equivocal cases? You went from 336 in 4 cores. Now you've got 336 in 3 cores, and there's 2 cores of 3 + 4 = 7 with maybe 10% or 20% pattern 4. And the guy looks like the slope is this. Or even more equivocal progression. Last year you had favorable intermediate risk, 3 + 4 = 7 with 10% pattern 4. Now you had 20% pattern 4, but the core size is like different, and like maybe it's not much difference in the disease. We're thinking about using a committee vote and saying, like, for all the cases, we're blessed by having an oncology conference, but for all the cases that are equivocal, that it's not hard. Yes, we definitely progress. We need to treat for life-saving reasons, not just because the trajectory appears to be bad. For all the cases that are equivocal, a committee vote. So when we run clinical trials as clinic, you often will have an independent review committee that will look at something and say, yep, this is progression. No, it's not progression. And imagine if you were the patient and you had the new biopsy results and it was not a clear-cut the same, not a clear-cut terrible, but you're in between. And now your physician tells you, I believe that you're safe to stay on surveillance. And indeed, when we showed you at our multiple disciplinary conference and committee of 5 of us, 10 of us, vote on your case, there was X amount of concordance. I think 80% concordance would that you have not progressed and that you should stay on surveillance. That patient, I would feel great as a patient. Oh, that's great. And say that they said, the committee said, look, we know it's not dramatic, but we think that it got worse enough. And 80% said we would treat you at this time. And the thing that you want to understand as the patient is, it's not a win for me if you're on surveillance and I realize that the trajectory is not flat.
Our next amazing sponsor is XY Wellness, a company I know a little bit about as co-founder and medical director of the company. XY Wellness is a company to help men renew, rebuild, and reclaim their health, their bodies, after a prostate cancer diagnosis. XY Wellness is a lifestyle company that helps provide a no-nonsense roadmap to health and wellness in men after they are diagnosed with prostate cancer. The hope with our program and what we see with many of our members is that men after prostate cancer tend to thrive, not only survive, through our program. To learn more about XY Wellness and its roadmap, please visit the link below in the show notes.
So you're not in the 25% that will never need treatment. The trajectory is like this. It's going up slowly, but the disease is getting out of hand. There's 2 things that can happen. One is the disease you can lose some treatment opportunities. You can lose opportunities to have excellent nerve sparing. You can lose opportunities for focal therapy. Those opportunities can be lost to you, which can give you better functional outcomes by you waiting and the disease gets bulkier. The second thing is, as the disease gets bulkier, or as you get more pattern 4 disease, or maybe as a genomic signature, like a Decipher molecular signature changes, now you've got disease that changes. I was talking about slopes that are flat, slopes that are like maybe 45 degrees, slopes that are much higher than 45 degrees. That's not really how cancer works. What cancer works is the slope is changing to 45-degree slope, and then at some point it develops enough genomic instability or something that there's enough bad actors in there that can change the whole slope entirely so that the curve becomes logarithmic, and you never want that either. And so I think on surveillance, you have to understand when something is impending, so that you can then say to the person, if we cure you this year, we can do it and you'll have great sexual function. Maybe you can get radiation with no hormonal therapy, surgery with less chance of needing early salvage therapy, maybe for focal therapy. Now, the advantage of holding on to surveillance as long as possible is we're always developing new strategies. Where there's always new clinical trials going on. There's ways of putting some of these modifications that are dietary. Maybe we can get them into a bottle somehow. There's a trial that's finished. I'm curious about the Provent trial, which was using it's not really a vaccine, but like an MB to see if that can modulate. So there's reasons to stay on surveillance, but I think that you have to understand when something is happening. And the example I give my patients is you could be in a car that's rolling very slowly, and that's fine. And then you can hit the brakes anytime you want. You can see that there's a cliff up ahead. Even if the car is rolling slowly, you definitely want to hit the brakes before you're over the cliff. And so I think that for my patients that are at that very low risk, to de-escalate my surveillance, those guys, I'm following them much closer, often doing biopsies about every years, and then I'm spacing it out because I want to really know that their cancer is not going to go off that cliff, and that we don't.
Is there another way other than biopsies that you feel comfortable? So let's say the MRI is stable,
the MRI
looks the same. And talking about genomics, what is the role of genomics in all of this?
So
is it differentiated? Okay. Yeah.
So the things, like I mentioned, the things that we've seen in our cohort that I think are the differentiators of cancers that you can do less follow-up for or more follow-up for is genomically with the Decipher. If you have a lower Decipher score versus a high one, a high Decipher score can be bad news. You need close surveillance. That's above 0.6. We talked about MRI. An MRI PIRADS 5 means that there's a 1.5 centimeter tumor. So even if that's all low-grade tumor, you think about like hits on goal, like how many of these like bad actors are having a chance to do something worse. And then PSA densities, and so how much PSA you're making per gram of prostate tissue. In Lenny Marks, who's from UCLA, he had a paper a while back where they looked at patients that had MRI and were on surveillance. And he looked for 4-7 progression, so hard line for progression. His guys that had PIRADS 5 lesions and higher PSA densities, about 100% of them came off surveillance in 2 years. So those are the factors: PSA density, high genomic score, PIRADS 5 follow-up, at least yearly. I feel like 3 years of that before I kind of space it out. I don't feel comfortable in the early going saying that the MRI can supplant a biopsy. I'm not quite ready for that. I think once I establish the line you're on and I have the data points, then my comfort gets higher. So I feel like more assessments up front leads to longer non-assessments down the road is what I'm saying for the higher risk cancers, because then I can have a real understanding of what's your cancer actually doing. And to your point, another undiscovered country is, as you're assessing them up front, it's interesting to reinforce a lot of these lifestyle modifications, because maybe they can make their prostate a hostile environment. There will be less progression. A lot of the data that's out there already is sort of muddled because people were coming off of surveillance for all sorts of reasons. It wasn't as tight as we could say. So, sorry, there's a lot to unpack there.
Yep. No, I appreciate that. Why do you think so actually I have two questions. My mind is kind of going in different directions. What do you do with a Gleason 6? So you do a biopsy, Gleason 6. The PIRADS score is 5. Are you automatically thinking, am I missing something? Or maybe the radiologist read it wrong. Maybe we need a second opinion on what are you thinking?
Yeah, there's a lot to unpack there. I usually am not taking that guy to immediate treatment. In some rare cases I am. But the things to look at are the following. So one is, it's PIRADS 5, you biopsy it and it's say Gleason grade group 1. what I look at is, okay, well, was that Pirates 5 really a legit lesion? Like, was it a Pirates 5 because full of cancer, or was it Pirates 5 because there was cancer, but also like this cloud of inflammation around it that somehow restricted the diffusion and did other things to make the MRI look that way? So I look at like, well, how much of my core was involved? I had a guy like this just a few days ago that we had a big Pirates 5 lesion, so 2 centimeter lesion in the prostate. The biopsy cores were about involved. So when you look at the length of the needle involvement, it says 1.5 centimeters involved by cancer. So that guy legitimately has that much cancer. That's different than the guy who has a Pirates 5 lesion and Gleason grade group 1 and is discontinuously involved in that lesion. Then that's a person where somehow it kicked off some microenvironment thing that faked out the scan. I will say that I've certainly seen outside MRIs. We're talking about why not everyone uses MRIs up front. Outside MRIs that are called Pirates 5. And even when I look at it, I'm like, well, that's a BPH nodule. That's not Pirates 5. And then, because I do a lot of this, I will then have my expert radiologist say, can you overread this outside study? We need just some more homogenation there. But for the patients, if they don't quite have that insight, if they're looking at everything and says a Pirates 5 lesion, and then it's Gleason grade group 1, the next thing to ask themselves is, okay, was it a real, legitimately that much cancer? The second thing I look at then is I'll also do from the genomics, if you have the Decipher score, is it like a bulky amount of low-grade tumor that's not really doing much genomically or doing more genomically? So like the guy I mentioned from a couple of days back, but a 2 centimeter lesion, and we're actually going to treat him. He's one of the rare low-grade cancers that we're going to treat. He's Gleason grade group 1, and we usually wouldn't do treatment, but he has 2.5 centimeters lesion, Pirates 5. The body cores were up to 100% core involvement, so it's legit. His Decipher genomic score was on the higher side of risk, is about 0.61. And I think that he's checking all the boxes that I know that are bad. His PSA density is high. He's like about a 34-gram prostate. His PSA is around 8. So there's all these things he's checking off. Maybe we'll end up over-treating him. I don't know. But there's too many like yellow flags. I'm seeing too much smoke. And these are the rare cases like that. So what you want to do, as you're kind of putting out, is in almost every other Gleason grade group 1 case, the person should be on surveillance. NCCN says preferred. AUA says that's like, you've got to do it because you deserve to see if 1 year later, did the MRI change? Is it now dated to a 4? On the biopsy, was there a change? And you owe that to yourself as a patient to see that. And most of the time, particularly if the genomics are low or other things, you're okay watching this glob of tumor that's not doing anything. It's like having a big mole or something that definitely is not melanoma. Most of the time you're okay. So I would say preferred surveillance in almost any low-grade patient. One thing that I was surprised by is the volume of low-grade cancer found doesn't matter that much as I used to think it does. But I think that there's, like I mentioned, just for the audience, like a prostate itself with a 2.5 centimeter, that's most of the prostate, like a 35-gram prostate. So
that size is relative to that size of the tumor is relative to the size of the whole gland.
Well, I think that what I'm saying to the patient, to the size is one thing. The gland can be huge, and you can still have a big tumor in a big gland. But I'm just telling the patients, like when they think about a prostate, and they're saying, well, the prostate's the size of a walnut for a normal prostate. A walnut, if you think about it, we're used to inches. 3 centimeters is like inch and some change. That you're getting towards like most of the walnut, depending on how. So that was just like for frame of reference. A big tumor in a big prostate is still a big tumor. Is everything, just to be clear?
Right. A big tumor is despite the size of the prostate.
Yeah, exactly.
Ash, why do I find in my world, in my life, and so there are groups of integrative and functional medicine doctors that they're saying, Gio, you're the prostate guy in our space. What do you do? What do you look for? And in the world of integrative and functional medicine, we're very data driven. Like we like data. Like sometimes, honestly, some of my colleagues order things like, oh, wait, that's too much. What do you plan to do with this when the results come in? I love genomic testing. I would order it on every patient. More information, better. I'd rather know than not know. Some of our colleagues, more like your colleagues, are kind of not big genetic people. Give me the MRI, the histology from the reading, and PSA density, call it a day. I'll make all my decisions based on that, and certainly not looking at genomics after the prostate is removed. Why the difference
You
in
know,
approach and opinion?
yeah, I think I can't speak to why I think the way they do. Everyone has a different threshold option. I was mentioning that there's like some level 1B evidence behind Decipher. It's not level 1A evidence, and which means that there hasn't been a good prospective randomized study that's completed that's showing you that this is really moving the needle a lot. And I think that part of it is you have to do something with that information. See where that information is being baked in is how intensive my surveillance strategy is going to be. Because like some people will say, well, I'm going to do surveillance anyways. And I think if you really push them and you ask like, well, what exactly is your surveillance protocol and why? And what a lot of us will do, and I think that this is an area that needs more study, and I don't want to, but what a lot of us will do is we will visualize it so much that we're almost semi making it up as we go along, and then we can't learn as much. But I'll give you an example outside of surveillance with genomics, and just to talk about practice patterns and how people might see things different or not. So we'll use the Decipher Genomics, which for the audience is a gene expression test done on prostate cancer that you can do it on your biopsy tissue or a prostatectomy tissue.
So to be fair, there are a couple of other companies that do the same thing.
There are, but they don't do the same thing. So there's Polaris that does the cell cycle progression score, and Oncotype DX prostate does the genomic prostate score. Now the NCCN, because there's a lot of noise and there's a lot of the companies will have data here, data there, but not the same level. So what the NCCN did this year is they have a table. This is the National Comprehensive Cancer Network, and they say we're going to summarize for you as the providers what's the level of evidence around these different genomic tests at biopsy, at prostatectomy. For Decipher, because there's randomized controlled trials that then have been post hoc and analyzed with that test, it's level 1B evidence at biopsy and at prostatectomy. Mm-hmm. For Polaris, which looks at just one pathway, cell cycle progression, or Oncotype DX prostate that looks at a few selected genes that were kind of curated, those have level 3C or level 4D evidence behind them. So low level of evidence, conflicting evidence supporting those tests. So I don't use those tests. They have a low level of evidence, low level of validation. They're not the same test. The Decipher was a transcriptome that then agnostically it saw these things and they tailored it to look at metastatic progression, but that it doesn't predict all these things. So they're not the same test. And obviously, and I should say full disclosure, I've collaborated with Myriad, who makes cell cycle progression before. I collaborate a lot with Decipher, and I'm a consultant for Decipher. But it's not me saying that. The NCCN is showing you, here's our synopsis of level of evidence. So for the providers listening, if you're going to use tissue and use dollars and use stuff for the patient test, you want a test that's the most accurate test and is going to add the most value. And how do you determine the accuracy of the test? It's by what's the level of validation behind it? Is it consistently showing value? And there's only one gene expression test in prostate cancer that is showing that value. It's Decipher. And so
thank you for breaking that down. I appreciate that very much. Yeah.
So let's take with that Decipher. So the unfavorable intermediate risk prostate cancer patient who decides to get treatment, and they decide to get treatment with radiation, right? And for that guy, we used to think, well, we'll do radiation, and we should have 6 months or 4 to 6 months of androgen deprivation therapy to make that radiation work. And we used to think that we used to be very cancer focused. We'd say that's what we want to do. But there's a lot of evidence that like the amount of absolute benefit can be kind of marginal, and the amount of detriment, particularly for some men, can be sort of bigger than that. And so how do we decide who's who? And there was the folks at Decide paired up with the radiation therapy oncology group, now G, and they had looked at some post hoc analysis of randomized data. And it showed that if you were unfavorable intermediate risk and had a low Decipher, and that you just had maybe one unfavorable intermediate risk feature or something like that, you had excellent outcomes with just radiation alone. And the NCCN kind of breaks that down now. That if your Decipher is like 0.45, unfavorable intermediate risk, radiation alone is going to do great. You probably don't need the 6 months of hormonal therapy that can cause all the bone, sexual, cardiovascular side effects.
And you combine that with Arterial AI. Does Arterial AI currently use a genomic to come up with that?
So Arterial AI is a different animal. Arterial AI is completely separate, similar validation evidence for that R2G stuff. It's taking in pathology where basically it has a digitized slide and it takes in factors like the Gleason grade, the PSA that you fed it, the stage, and then it has a machine learning thing that takes all those things together in an algorithm, and then
No genomics.
no genomics.
Okay.
And then it spits that into, here's what we think for risk assessment. And you bring up a good point. Arteria AI it's a novel thing. We have not really used digital and machine learning to do prognostic assessments, right?
Mm-hmm.
And there are some, I don't use Arteria AI routinely in my practice yet. There are some caveats around that. For example, the slides that they used were a decade or so older, and could the machine learning get faked out? I don't know. I think in terms of studying it, I definitely am keen on that. And maybe as it evolves, as we understand, I mean, machine learning is everywhere for everybody, but as it evolves, and we're be able to put more data into this machine learning algorithm, just like Arteria AI is taking clinical features you put in and the digital features you put in and spitting out the score that's probably better, and in data it shows it's better than just what you did yourself crudely. If we can put genomics in on top of that, maybe we can even push it further, but that's like TBD. But back to like where we are now. So the question is,
and back to, not to complete derail, because I'm loving this conversation. We could go on for sure, and you could take this wherever you'd like. Why do some of the colleagues, your colleagues, my colleagues,
that's what I'm saying.
colleagues?
So for me right now, for genomics, in that unfavorable intermediate guy, right? There's level 1B evidence that if I see that guy in my practice, they're 437 and they have a favorable decipher. Look, I think you can get radiation, no hormonal therapy. I feel really good about that because there's been that level 1B evidence, right? Some of my partners say, no, that level 1B evidence, it's a post hoc retrospective analysis. For me to really change my practice pattern, I need to have that level 1 evidence. And luckily, we have some trials open for them, like the NRG trials, prospective, and they're like, if I'm not going to roll them on a trial, that I'm not going to deal with that. Some of my colleagues are not ordering it because they don't make that decision. Some of them are surgeons, and they say, well, the radiation oncologist can make that decision. I'm a surgeon. It's not going to affect my surgical approach. If this guy wants surgery with me, the decipher is not going to tell me much, maybe post-operatively, and so I'm not going to do that. For me, when I believe in, I often find myself to be slightly on the side of early adopter and certainly away from being a laggard. So once the question is, how does the evidence speak to you? And I tend to be more an early adopter. And so some people are just a little bit more, just need more information to fully come along to it. And also for me,
you can muddle the waters too, Ash, right? So, okay, Gleason 6, everything else looks fine. Great, you're active surveillance. Wait a minute, high risk Gleason 6. Now,
the other thing too is, right? And that's the second thing too that we're going to talk about.
Meanwhile, he's saying, look, I'm trying to protect the patient. I'm trying to say, you don't need anything. And now kind of muddles the water.
There's multiple other avenues. Like the patient has Gleason 347. Really? Did you have a second opinion of pathologist? Who read it? That's subjective, right? And like you were mentioning the MRI, is it a fake out? Is it not? And for me, I want to collapse my decisional uncertainty. I like pathways, and I like lots of information up front. Like some of my colleagues for PET PSMA, which we're not talking about today. Some of my colleagues, high risk guy, or unfavorable intermediate risk guy. Society of Nuclear Medicine, Molecular Imaging, CCN all say that you can do a PET PSMA in that scenario, unfavorable
prior to treatment.
Some of my colleagues will be like, well, I'm not going to get that in this patient. Well, lymph node comes up positive. Then I can't do what I wanted to do. I don't like, let me get a complete picture up front. If I can make my first decision the best decision, that's going to help us on the back end. So some of it is perspectives, and and I think for debate here, some people think about, again, the system versus cost of individuals. And also and some people, like I mentioned, are getting forced into, by the medical system, shorter and shorter conversations with our patients. So in other words, like if I get more information, I've got to talk to you about that more information and really get into the nuance of what are we going to do for you. And I'll tell the patients also, not every provider is like the people that are on Dr. Gio's podcasts. And sometimes they'll get information and they won't understand how they're going to use it and the nuance behind it. They're just getting it to get it. And it can confuse you, the patient. It can confuse even the provider. And I think that we just have to, I think, pathway medicine. And then if we were incorporating these things into those pathways, and we could see which ones are the winners, which ones are the losers, how do we decrease the cost of them, that gets there. But for now, where I'm looking at the patient, what I like is as much information as I can, enough as much useful information as I can. You don't want
Hmm.
noise.
Yeah.
You
Right.
want
Right.
things
Right.
that I believe that are of use,
Yeah.
and then I proceed to making my final decision. And so that's why I use genomics pretty routinely. Our radiation oncologists use it quite routinely at Northwestern. Decisions about ADT or not, but
Mm.
I wouldn't fault someone who says I'm not going to use it until off trial or until we see the final. I wouldn't say you're wrong, and I've certainly been wrong before, or at least my conceptions have been wrong before on things where I thought this is important and it ended up being less important than I thought. Like a different genetic sphere, which is an advanced prostate cancer, germline or DNA based genetics. It's important to understand your susceptibility for something called PARP inhibitors that capitalize on DNA break damage. And if you're a BRCA carrier where BRCA2 is mutated, then you're going to be more likely to be susceptible to a PARP inhibitor. I thought that would be true also other DNA damage repair, like maybe also if you had a PALB2 or a RAD50 mutation. And it turns out that BRCA is really leading most of the way there. And so if we rewinded that data, and I just saw someone in my office and they had a mutation in a DNA there, and I thought we want to add on something to my therapy, I might have added a PARP inhibitor and I would have been wrong. And it's so you never know. It's the danger of being at the vanguard. But I like to have, I think for the patient all home, complete information up front and then deciding what you want to do for it. And to the NCCN credit, and like, again, he's a close friend and full disclosure, but also a person and an expert in prostate cancer, Ted Schaefer. For the NCCN credit, he leads that panel. All the members, Dan Spratt, does a lot in the risk.
Cleveland. Yeah.
Yeah, what they tried to do was for the things like genomics that maybe there's level 1B evidence, but they're not mandating use of the test. They now put in the guidelines. How do you use the test? If you get this score, do that. If you get this score, do this. They do it. They don't do it for the other tests. They just do it for Decipher. But the nice thing about that is we want to be more prescriptive. We can't have every doctor be a key opinion leader and because we can't serve the whole population that way. So we have to like sort of just spell out if A, then B. And like, anyways, so the long conversations are that. But if I was the patient, I'd want complete information to know how aggressive I want to be. If I'm not going to be aggressive, I want to do surveillance. What does that surveillance look like? Can I afford to have almost no biopsies? Or do I need to be really hawkish on this and plan my life around the idea that there's a 50 to 80% chance that I'm going to have progression, that I'm going to have treatment in the next 5 years? How do I plan my life around that? And sometimes you can plan your life around it. Sometimes you can't. And as you mentioned, the things you can certainly plan around if you're on that surveillance pathway is optimizing your health, because it's going to make you maybe have longer to progression, but certainly live longer and do better with therapies.
Sure.
Yeah, for sure. Yeah.
Sure. The way I present it, of course, because I don't have level 1 evidence, right? But the way I present it is maybe there's less progression. Maybe there's no progression. We're trying to create a microenvironment. We're still figuring out what this microenvironment scenario means. If you need treatment, you're going to do way better if your body's nice and strong and fit. Way better than not. So I just think it's just a win and a motivating factor. You and I wake up in the morning. I got to tell people that motivation. You think I wake up in the morning motivated to go to the gym? I'm not motivated. I'll tell you what motivates though. A cancer diagnosis is like, yep, I'm ready. And you're thinking and visualizing cancer cells being depleted.
I'll say something else, which you've probably said before in your podcast. For the patients listening, you already know this. For the men listening, you already know this. But that is true what you said. But once you start going to the gym or going for a run or going for a walk or spending that time on yourself or having that healthy meal or doing that little bit of meditation, then what you find is you do wake up in the morning and you say, I can't wait to get out there for my morning walk. I can't wait to get out there in the gym. I can't wait to work on my health. I agree with you completely. And as you probably told the audience, once you get on that train and you really hadn't already what good living is, it is better.
You get a high. There's a high from it.
Yeah.
And
it feeds forward.
Somebody asked me recently, I gave out ground rounds at Mount Sinai, Miami. And one of the questions from one of the attendees said, look, I see a lot of patients. How they're not really motivated. And he says, how do I know it would help them with their ED. And what do you find in your practice? I said, well, there's a spectrum of motivations, low, moderate, and high. The low motivated people is, well, maybe the diagnosis is not enough. Maybe, like, why am I doing this? Men on average really don't care about health. They care about performance. They start caring about health where then if it starts impeding their performance, or if there's a diagnosis on average. What you're saying is, hey, you keep doing it, and you're gonna say, wait, I can't wait tomorrow to go. And I agree with that. It takes a minute or
Oh
a
yeah,
while,
you got to get
right, to get to that point. You're on that
absolutely.
treadmill and you're huffing and puffing. That doesn't feel good. Keep doing it, and then you do meditation running,
Yeah.
where now you don't have to worry about your lungs and running out of air. You're just in a zone and you just run and you just zoned out and meditating. And that is beautiful. But it takes a while and consistency
Yeah.
to get there.
And unfortunately, I have to say, and we're under a lot of pressures to see a lot of patients and things like that. I have to say, I don't do a great job, or I could do a better job. And I think resources like directing patients to this podcast and others can help them think of things. But when I think about behavioral change, I really like, there's a model called COMB or COMB. It's like for behavioral changes, the B, the person has to have, or the system has to have capacity, has to have like opportunity. And I've been thinking about that model a lot. So now I talk to my patients a little bit about like, well, do they have the capacity and opportunity for these things? How will they find that? Do they have the motivation? Do they have the motivation? And like you said, it can be self-motivating. The problem is, and I have to say, and this is, I'm sorry to say this for the patients, but we are, at least for myself, that to be efficient and see the amount of patients with the baby boomers and everyone as much as we can, we have to get really well organized as providers. And like, thank you for what you do, Dr. Gio. Have podcasts for others like you that are making these more digestible forms for the patients. That's one of my main goals, besides the pathways and being more prescriptive about how we're doing surveillance, how we're deciding you come off, what are our criteria for being on, is the testing we're doing of value, how do we have to probably do some over testing in a trial format to understand that better. The second thing I want to try to get more prescriptive on, like, what resources should we be handing the patient or showing the patient or pushing maybe through the EMR, this link that goes to a video or to a podcast to say, like, look, these are the things you should be looking at on your free time. Because the other thing, as a person for myself, not as a physician or anything, is people will tell me the same message will come in a dozen different ways until I finally get on track. And I don't know what it is when the magic happens that changes me to then do something different. But back to, I think the major thing is, for surveillance, for the patients that are listening, if you have favorable intermediate risk disease or less, you should be highly considering not starting out your management strategy on surveillance. You should realize that, like, there's tools that can help your doctor, your MRI, which you already have usually. Maybe if you didn't, you definitely need one. Your PSA density, your characteristics on the histology, meaning, like, is there things we didn't talk about for pattern 4, crib forming, intraductal. There's things about your family history that might play a role. There's things about your cancer that can put you on different pathways of surveillance that are less intense or more intense. Genomics might be able to help there as well. You owe it to yourself to optimize your lifestyle, and to realize that there's most patients, right, you see that do surveillance will have to come off surveillance and get treatment. And it's one thing of, like, understanding where you are on that trajectory and if it's coming or not. And the thing to understand is, like, you can gain a lot still by being on surveillance, but you can't forget about the cancer, meaning that there are always new innovations coming down the road that can help you, et cetera. And that's kind of the synopsis for the patients. And it's now.
I appreciate that.
Yeah.
I usually end with asking my guests to have final words.
Oh, sorry.
You just did it.
Yeah.
I appreciate that. Dr. Ashley Ross, faculty member at Northwestern Department of Urology. Ash, I can't tell you how much I appreciate your knowledge, your time, your passion, and all you do to make our men after a prostate diagnosis better. And I appreciate everything about you. So thanks so much for being on. How can people find you if they want to find you?
Oh, I think, they can go to the Northwestern. That works very well. I think that's the major way. I don't have my own page or a podcast or whatnot. So I would say, if you Google me, I will Ashley Ross or Ashley E. Ross. I do come up. If you say Ashley Ross Prostate, I'm all over the place. And our staff at Northwestern for ACT has been one of our focal points to try to be able to help patients get in and get more access to people like me, to other colleagues of mine that are also experts. So it shouldn't be that difficult, and I hope it's not going to be to read for the listeners. If you get some chatter, Dr. Gio, about, hey, I want to talk to this guy, I can't talk to him, then I will reassess how we're doing it and figure out if we can get a special access line. So
No worries. I will put your website or method of find you on our show notes. Ashley Ross. Ash, thank you so much. Have a great evening and hope to see you in person soon.
My pleasure. Thanks, Dr. Gio, and thank you to all the listeners for their time.
Thank you, everyone, for listening. This is just another one. I'm so humbled to have experts like Ashley Ross on the podcast. I hope you got a lot from it. In fact, I know you did. There's a lot of information here to unpack, but this will help you have a better conversation with your physician if you're in active surveillance scenario. So all the best to you all. Much love to you all. And I'll see you next time. Dr. Gio here, signing off. All the best. Tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Gio Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. And now for a brief disclaimer. This podcast is for general information only, and we're not forming a doctor-patient relationship through this medium. The use of the information and all links associated with this podcast is at the listener's risk and is not to replace medical advice from a physician or a healthcare practitioner. Lastly, thoughts and opinions related to this podcast are my own and may not reflect the views of any institution or organization I'm associated with. I'll see you next time.